Out today. We're super excited to be doing another Anatomic Pathology Friday. Today we have 3 presentations from 3 of our second-year students. The first will be a squamous cell carcinoma of the vulva by Lauren Wheelock. After, we'll hear from Kezira Horton, the insidious mass, a case of clear cell renal cell carcinoma, followed by Zoie Ziesmer, atrophic endometrium to serous endometrial carcinoma, a rare but aggressive transformation. With that being said, we will go ahead and pass our screen off to Lauren Wheelock, who will be presenting remotely today.
All right, let me see if I can get this to work. There we go. Can everybody see?
Yep, we can see you.
Beautiful? Okay. Hi, everyone. My name's Lauren. I am a second-year PA student at UTHSC, and this is squamous cell carcinoma of the vulva. So let's start with an overview of this presentation. So I'll begin by introducing our pathology. We'll then review anatomy and histology of both the skin and vulva to include both gross and microanatomy. I'll then dive into the pathology and pathophysiology of squamous cell carcinoma to include precursor lesions. I'll then introduce our case. We'll talk about the AJCC Cancer Staging Manual, and we'll finish up with patient prognosis as well as final diagnosis. So here are some learning objectives. So by the end of this presentation, you all should be able to identify the anatomic components of the vulva, understand and identify the histologic components of skin, the labia majora and the labia minora. You should be able to name the common clinical presentations and precursor lesions of squamous cell carcinoma of the vulva. You should be able to contrast well-differentiated versus poorly differentiated squamous cell carcinoma, list the common genetic mutations in squamous cell carcinoma, and finally, understand the AJCC Cancer Staging Manual for vulvar carcinoma. And so with that, let's begin. So vulvar carcinoma is an incredibly uncommon carcinoma and only accounted for around 4% of all gynecological malignancies diagnosed in the year 2021. Of that 4%, the most common type of vulvar carcinoma is squamous cell carcinoma, which accounts for around 80% of all vulvar carcinoma diagnoses. Typically, vulvar carcinoma is asymptomatic. However, if patients do experience symptoms, the most common seem to be pruritus or pain with a new ulcer. Bleeding and abnormal discharge can also occur, although that's even more uncommon than symptoms in the first place. Biopsy is needed for diagnosis. One of the studies that I read really emphasized the importance of a biopsy specimen that includes greatest depth of invasion, although that's often not possible. Surgical excision is the most common form of treatment for squamous or for vulvar carcinoma in general. And metastasis is rare. However, these lesions do spread via lymphatics. So if metastasis were to occur, the most common site for metastasis to happen would be the femoral or inguinal lymph nodes. Other metastasis outside of that is incredibly rare. So let's talk about the anatomy that is the vulva. So the vulva accounts for all of the external genitalia found on a female body. So it will account for the labia majora, which I'm hoping everybody can see my cursor, would account for the skin component right out here. The labia minora, which is this pink area right here. The vaginal opening, which is this area right here. The vestibule, which is just posterior to the vaginal opening, and the greater and lesser vestibular glands. Now, the greater vestibular gland is more commonly known to us in pathology as the Bartholin's gland, and that's located posterior and almost lateral to the vaginal opening. And the lesser vestibular gland is located just anterior to the vaginal opening, and that's also more commonly known as the periurethral or the Skene's gland. So because this case does end up just sort of being a skin excision, I thought it was important to highlight where on the body it was located, especially since the skin excision does not include any other kind of anatomic landmarks. So when we're talking about gross photos or anything like that, please keep the area that's highlighted in the red box in mind. So now we'll talk about some histology of the skin. So the skin is composed of two layers, the epidermis and the epidermis being superficial and the dermis being deep to that. We'll start with the dermis. So again, the dermis lies between the epidermis and the subcutaneous tissue. It's composed primarily of collagen. However, there is also elastin, blood vessels, nerves, and sweat glands found in the dermis. The primary cell type in this layer is the fibroblast, and fibroblasts are responsible for producing collagen, elastin, and other proteins. It's further divided into the papillary and reticular layers. So the papillary layer is the superficial most layer of the dermis. It's located just beneath the dermal epidermal junction, and it's composed primarily of fibrocytes, collagen, and blood vessels. Below that is the reticular dermis, which is typically much thicker and contains fewer fibrocytes, but a denser collection of collagen. So let's talk about the epidermis now. So the epidermis is composed of keratinocytes, and it has 4 layers. We'll start with the deepmost layer. That is the red layer in the picture on the left. And that is the basal layer, also called the stratum basale. And it's composed of stem cells that divide to form keratinocytes that will eventually migrate towards the surface. Also present in this layer are melanocytes and Merkel cells. So melanocytes help give the skin some of its pigmentation as well as provide UV protection. And the Merkel cells function as the skin's mechanoreceptor. Superficial to that, colored in pink on the picture on the left, is the spinous layer or the stratum spinosum. And in this layer, the cells are connected to each other via desmosomes. The desmosomes will give the cells in this layer their sort of characteristic spiny appearance, hence the name spinous layer. Superficial to that is the granular layer. And so in the granular layer, keratinocytes will have visible keratohyalin granules, and those granules will form with filaggrin to form profilaggrin. Now, profilaggrin is responsible for giving the skin its barrier formation as well as providing strength. And the final layer, the superficial most layer, which is sort of the pale orange colored cells in the picture, is the stratum corneum. So the keratinocytes in this layer have lost all of their organelles, hence why in this picture they're all kind of blank. Keratinocyte is considered complete in this layer, and the cells are attached together via desmosomes. They're also surrounded by lipids, which help provide the skin with some of its moisture control. Also present throughout the epidermis and the dermis are Langerhans cells, and they're specifically found in the spinosum, granulosum, and the dermis. Langerhans cells function as antigen-presenting cells that help provide the skin with some sort of immunologic protection. Unfortunately, Langerhans cells do decrease in number with increased exposure to UV light, which would create an ideal scenario for carcinoma development. So let's talk about the histological components of the vulva specifically. So like I've said previously, my case does not have any kind of actual anatomic landmarks, but it does involve both the labia majora and the labia minora. So both the labia majora and the labia minora are keratinized stratified squamous epithelium. And the main difference between these two structures is that in the labia majora, there are both sweat glands and hair follicles, and those are depicted as sort of those pale purple cloud-like features that are absent in the picture on the right, which depicts the labia minora. So let's talk about squamous cell carcinoma pathology. So squamous cell carcinoma is the second most common non-melanoma skin cancer. It accounts for around 20% of all skin cancer diagnoses. There's a lifetime risk development for non-Hispanic populations of between 14 and 20%. However, that percentage is continuously increasing. And typically these lesions present as a red scaly plaque. I've also seen a couple things that say non-healing wound. And they're typically in sun-exposed areas. So in the picture labeled A, we see a patient's nose with sort of a red-yellow scab-like looking lesion. And in the picture labeled B, we have a patient's forehead with a scabbed sort of nodular red lesion. There we go. More specifically for the vulva, however, again, squamous cell carcinoma accounts for 4% of all gynecological malignancies diagnosed in the year 2021. Clinically, it typically presents as a verrucous or white plaque. in women over the age of 60 years. A third of all squamous cell carcinoma of the vulva cases are related to HPV, while the remaining 2/3 are unrelated. So the overwhelming majority are unrelated to HPV. Of note, there was a 400% increase in the rate of precursor lesions for squamous cell carcinoma of the vulva between the year 1973 to 2000. And in the same time period, there was also a 20% increase in full-blown squamous cell carcinoma. The study that I read attributes this mainly to a greater increase in patients seeking treatment and less so to a greater increase in incidence overall. So histologically, the tumors are graded on a scale that talks about differentiation. So differentiation is defined as how well the malignant cells resemble their healthy cell counterparts. And so a well-differentiated squamous cell lesion would have cells that do look malignant, however, mainly resemble squamous cells. We'll also have all of those hallmarks of squamous cell carcinoma. So we'll have intracellular bridging, which is unfortunately kind of difficult to see on this picture, but there is some located right here. We also have a keratin pearl, which is that sort of pink, like almost amorphous looking blob. And we have basally located mitotic figures. So if you could find a basement membrane in this picture, the cells closest to that will have much darker nuclei and almost look as if they're splitting, which would account for mitotic figures. Conversely, poorly differentiated squamous cell carcinoma would indicate that the malignant cells do not resemble healthy squamous cells at all. And so in this picture, we've lost a lot of our hallmarks that are squamous cell carcinoma. We don't have keratin pearls. Intracellular bridging is quite difficult to appreciate. And the cells are arranged in a very haphazard pattern. So some risk factors for squamous cell carcinoma in general include UVA and UVB exposure. So UVB exposure specifically damages DNA that would normally be repaired in cells. However, if a damaged or mutated cell escapes the apoptotic cycle somehow, this could lead to carcinoma development. UVA specifically impairs the ability of suppressor T cells to attack mutated cells, such as previously mentioned, which would allow mutated cells to continue propagation. Mutations in the p53 tumor suppressor gene would also allow mutated cells to evade apoptosis within the cell cycle. And around 84% of all squamous cell carcinoma cases in general do have a mutation in p53. Also of importance is CDKN2A. So CDKN2A functions as a cyclin-dependent kinase inhibitor that inhibits cell division and growth. Around 58% of all squamous cell carcinoma cases do have a mutation in CDKN2A. Specifically for vulvar squamous cell carcinoma, again, we're mostly interested in high-risk HPV types such as 16 and 18. Human papillomavirus leads to squamous cell carcinoma as the proteins from these high-risk subtypes, again, 16 and 18, inhibit p53 as well as p16 and other apoptotic pathways. Immunocompromised individuals are especially susceptible to HPV-induced squamous cell carcinoma. Also of importance is chronic inflammation. So chronic inflammatory conditions like lichen planus, lichen sclerosus. One of the studies that I read also talked about lupus erythematosus as being a chronic inflammation disease that can lead to carcinoma development, can predispose to squamous cell carcinoma. However, typically the diagnosis of squamous cell carcinoma from a chronic inflammation disease happens many years later. Vulvar squamous cell carcinoma can develop, there are two pathways for development. There's the non-HPV related pathway and the HPV related pathway. We'll start with the non-HPV related pathway since 2/3 of all squamous cell carcinoma cases are not related to HPV. So I've mentioned lichen sclerosus quite a few times. It's one of our possible chronic inflammatory conditions that can lead to carcinoma development. And so histologically, what we'll see in lichen sclerosus is dermal atrophy, which is labeled with an E in the picture on the left. We'll We'll see diminished reedy ridges, which are labeled with an R, and those look much blunter compared to healthy epithelium. We'll see hyalinized collagen in the superficial most dermis, which is labeled with an H. We'll have inflammatory cells in the deeper dermis, which is labeled with an IN. And lichen sclerosus is a preceding diagnosis in between 15 to 30% of patients with differentiated vulvar intraepithelial neoplasia. So let's talk about differentiated vulvar intraepithelial neoplasia. So this is the, again, HPV independent pathway that results from high inflammatory states such as lichen sclerosus and lichen planus. This typically affects older women, specifically between their 60s and 80s, and will clinically present as a poorly defined white tan nodule. Histologically, what we'll see is acanthosis. So that is when the stratum corneum, the superficial most layer, holds on, the cells in that layer will hold on to their organelles. And so in the picture on the left, we see almost like polka dot looking figures in that layer. And that is keratinocyte nuclei that should not be there in normal epithelium. We'll also see parakeratosis. I'm sorry, acanthosis is epidermal thickening. Parakeratosis is what I've just said. Elongation and anastomosis of reedy ridges, and we'll have prominent intracellular bridging. Unfortunately, DVIN does have a fairly high rate of recurrence. Conversely, the HPV-dependent pathway, the precursor lesion is called high-grade squamous intraepithelial lesion, or abbreviated to HSIL. And again, this is associated with high-risk types of HPV, such as 16 and 18. HSIL typically affects younger women, specifically in their 30s to 50s, and patients that smoke are at an increased risk of developing HSIL. Clinically, HSIL presents as a verrucous or erythematous white macule on or near the labia. And histologically, it's composed of epithelial cells with a high nuclear to cytoplasmic ratio. So let's say one of our patients that we're talking about has gone through one of the pathways of pathogenesis. We have 3 clinically significant subtypes of vulvar squamous cell carcinoma that we're going to talk about. So the first, which is labeled A on the left side of the screen, is verrucous squamous cell carcinoma. And so verrucous squamous cell carcinoma will present as an exophytic warty growth that is histologically composed of closely packed and elongated reedy ridges that push into the dermis almost as like a pushing front of tumor. The tumor cells themselves have minimal atypia and have a low nuclear to cytoplasmic ratio. Verrucous SCC lesions typically do not metastasize and are generally only treated with surgical excision, making them the milder clinically significant subtype. The next subtype is sarcomatoid SCC, which is labeled B in the center of the screen, and these lesions are much more aggressive with a higher rate of metastasis and fatality when compared to verrucous squamous cell carcinoma. Histologically, sarcomatoid SCC will resemble a sarcoma, so it will be composed of malignant spindle cells with a high mitotic rate. The cells can be arranged in a sheet pattern, which is what's depicted in the picture, but they can also be arranged in a fascicular or in a storiform pattern. And finally, our last clinically significant subtype is infiltrative SCC. I find these lesions to be interesting because they're invasive via a single cell or a cord of cells rather than a pushing front of tumor. And those invasive cells will extend into the dermis or subcutaneous tissue. This subtype seems to be the most aggressive of all of these subtypes and has a much higher rate of recurrence after surgery when compared to verrucous and sarcomatoid. And because of that, infiltrative is mainly treated with surgical excision plus adjuvant therapy. And so with that, let's talk about our case. So I want to preface that my clinical history for this case was very, very limited. I was kind of only using the op note. But what I do know is that my patient was a 52-year-old African-American female that did not have a known HPV infection. She presented to clinic at some point with some kind of lesion on her labia that was biopsied and signed out as carcinoma in situ. So I do not know if she had DVIN or HSIL. We'll get into my theory on what happened later. And she was scheduled for a simple partial vulvectomy that did not include a lymph node dissection. And so this is what came across my bench. So it is just a skin excision. The suture designates 12 o'clock. And what we see is a white tan, really ill-defined exophytic mass. I measured the greatest dimension to be 2.5 centimeters. And this picture doesn't quite do the 6 o'clock margin justice. Down here, there is sort of a lip of skin that made me feel like the 6 o'clock margin was safe. However, I was quite concerned about the 3 o'clock margin, specifically right here. Because the lesion was fairly ill-defined, I couldn't tell if that gray area was just discoloration or if it was lesion extending to that margin. So before grossing this, I did consult the CAP protocol just to make sure I was going to do it correctly. And the CAP mentions 3 important sections that need to be included in the pathology report. The first being tumor to include deepest invasion. The second being tumor to include adjacent epithelium, and the final being resection margins. It mentioned that if the lesion was close enough to a resection margin, a perpendicular section should be taken. And so before we get into slicing, I thought I would provide you all with an ink map just because I can tell you how I've inked something all day, but it can be quite confusing to someone that did not gross the case. So for me, 12 to 3 o'clock was green, 3 to 6 was red, 6 to 9 was blue, 9 to 12 was yellow, and then the deep margin that you cannot see in this picture was black. So this is what we see upon cut surface. So I sliced it from 12 o'clock to 6 o'clock. I left my 12 o'clock and 6 o'clock slices just a little bit thicker than the middle slices for possible perpendicular sectioning. And of note, we have sort of this area right here, which I've coined our money slice. This has the most visible portion of tumor and the greatest point of invasion for the tumor. So if we zoom in, this is what we see. We have very white, sort of firm cut surfaces, and the tumor looks invasive via a pushing front of tumor rather than a cord of cells or an ill-defined area of invasion. And so I mentioned the CAP protocol mentioning tumor thickness and depth of invasion. So tumor thickness is measured from the surface of the tumor or the bottom of the granular layer to the deepest point of invasion. Conversely, depth of invasion is measured from the basement membrane from the adjacent most uninvolved reedy ridge to the deepest point of tumor invasion. And depth of invasion is specifically measured in millimeters. So to do that grossly, this is how I measured tumor thickness. Again, our money slice has sort of the deepest point of invasion that I could see grossly. And so I took my ruler and pulled it straight up, and I measured our tumor thickness to be about 0.6 centimeters. Greatest depth of invasion was measured like so. So again, I found our greatest point of tumor invasion and compared that to the adjacent uninvolved epithelium and measured a gross invasion of 3 millimeters. So let's talk about what we see under the scope. So this is an overview of our tumor. It's very purple, very malignant looking. And if we zoom in, we have all of those wonderful hallmarks of squamous cell carcinoma, and we have cells that very much resemble squamous cells. So we have intracellular bridging, specifically right here. I thought that was a very good example. We have a keratin pearl in the center of the picture on the left. And we have parakeratosis in the picture on the right. It is quite difficult to see, but there is an area. Let me move me. Sorry, everybody. There's an area right here of parakeratosis. And so I was concerned because I wasn't seeing invasion at first, and then I kept looking, and here's our invasive component. So if you follow this basement membrane around all the way down here, we have the invasive component. We see tumor invading into that underlying soft tissue and stroma. We also have a teeny tiny bit of invasion here that I thought was really interesting and had to show you all. And I kept mentioning that I was quite worried about the 3 o'clock margin, and unfortunately here is why. So if we remember, I did ink the 3 o'clock margin as green, and what we see here with the arrows is red ink right on tumor. So unfortunately her 3 o'clock margin was positive. So AJCC has a cancer staging manual for vulvar carcinoma, and of interest, there is no T4. It only goes to a T3, which I found very, very interesting. So T1 is further divided into T1A and T1B. So T1A is comprised of lesions that are 2 centimeters or less in greatest dimension that are confined to the vulva or the perineum. and have a stromal invasion component of 1 millimeter or less. T1B accounts for lesions that measure in at greater than 2 centimeters and have a stromal invasive component of more than 1 millimeter, but T1B will still be confined to the vulva or perineum. T2 accounts for tumors of any size that extend into adjacent perineal structures like the lower or distal third of the urethra, the lower or distal third of the vagina, or anal involvement. And T3, our final stage, accounts for tumors of any size with extension to more distant structures, such as the upper or proximal 2/3 of the urethra, the upper or proximal 2/3 of the vagina, bladder mucosa, or rectal mucosa. It also mentions bone. A lot of the studies that I read mentioned that vulvar carcinoma very rarely metastasizes to bone or invades into bone. The AJCC Cancer Staging Manual also talks about grading. So again, differentiation is defined as how closely those malignant cells resemble their healthy counterparts, and that's graded on a G scale. So G1 would be well differentiated, meaning those cells do match their healthy counterparts. G2 would be moderately differentiated, and G3 would be poorly differentiated. For our case specifically, we are concerned with T1B because the greatest dimension of our lesion was 2.5 centimeters, and it did have an invasive component of 3 millimeters. However, the lesion did remain confined to the vulva. And histologically, we saw cells that were very malignant, but they did very much resemble squamous cells. We had all of those classic squamous cell hallmark components, such as keratin pearls and intracellular bridging. So G1 seems to fit our criteria here the best. So the final diagnosis of this case was well-differentiated keratinizing squamous cell carcinoma of the vulva with a pathologic stage of a T1B. Again, we didn't receive lymph nodes, so we could not give her an end stage, and she has no known metastasis, so we could not give her an M stage either. Patient prognosis-wise, patients with PT1B or P2 disease have a greater than 8% risk of metastasis and a fairly high rate of local recurrence. Of note, most of the recurrences will happen within 2 years after initial treatment. The 10-year survival rate after surgery overall is greater than 90%. So these lesions do have a fairly high survival rate. For my patient specifically, she matches the literature fairly well for the non-HPV related pathway for everything except for her age. So the non-HPV related pathway typically affects older women between the ages of 60 and 80, and she was 52, so she was quite young. However, she is older than the HPV dependent pathway. And her rate of local recurrence is fairly high because her 3 o'clock margin was unfortunately positive. However, her 10-year survival specifically is greater than 90%, so she should be just fine. And with that, here are my sources. Any questions?
So with the positive margin, is there any chance that they would go back, or since the survival rate is so good, would they just kind of leave it alone unless she has another problem?
So that's a good question, and I honestly asked my pathologist the same thing because I was a little confused. He had said that if it's warranted, she can absolutely have them go back in and take off more of that 3 o'clock margin. However, because the 10-year survival rate is fairly high, it's typically treated just by monitoring, although he wasn't entirely positive with our specific surgeon what the treatment plan was.
Thank you, Lauren. Excellent work. All right, we'll continue our today's presentations. Next up is Kezira Horton.
My name is Kezira Horton, and the title of my presentation is The Insidious Mass, a Case of Clear Cell Renal Cell Carcinoma. By the end of this presentation, the listeners will be able to list and identify the structures of the kidney used to obtain the appropriate orientation, identify the histologic features of clear cell renal cell carcinoma and explain how these features correlate to a diagnosis, use the WHO/ISUP histologic grading system to accurately grade clear cell carcinomas, interpret IHC stains of clear cell carcinomas and determine whether they are negative or positive, and compare and contrast clear cell carcinomas with xanthogranulomatous pyelonephritis using histologic and IHC differences. My presentation will flow as follows. First, we will start with the kidney and its relevant anatomy and microanatomy. Then we will discuss the AAPA grossing guidelines for renal cell carcinomas. Next will be my case study to include IHC staining and the diagnosis. Then we will talk about clear cell renal cell carcinoma, including its etiology, pathophysiology, morphology, and clinical course. And we will finish with xanthogranulomatous pyelonephritis. Now the kidneys and their anatomy. The kidneys are a part of the urinary system, and they are two bean-shaped organs located beneath the rib cage on either side of the spine. They have many functions. However, their most important function includes removing waste and toxins such as urea and creatinine from the blood. They also help maintain a healthy balance of electrolytes. Approximately half a cup of blood is filtered every minute, and other functions of the kidneys include maintaining the pH balance of the blood, producing glucose, regulating blood pressure by producing renin, producing calcitriol, and producing erythropoietin, which is a hormone responsible for the production of red blood cells in the bone marrow. Superiorly to the kidneys are the adrenal glands, and due to their proximity to the kidneys, they are worth mentioning. The adrenal glands are endocrine organs responsible for secreting hormones such as aldosterone, cortisol, and androgens. Typically, the right kidney weighs 140 grams and the left kidney weighs 150 grams. This difference in weight is due to the position of the right kidney to accommodate the size and structure of the liver. The outer structures of the kidney include the perinephric adipose, Gerota's fascia, the renal capsule, and the renal vein and artery and ureter. The renal vein, artery, and ureter all enter the kidney at the hilum. The outer structures of the kidneys allow it to be oriented. It is important to be able to orient the kidneys to confirm the laterality when grossing radical nephrectomy specimens. To orient the kidneys, you first have to identify Gerota's fascia, the renal vein, the renal artery, and the ureter. Gerota's fascia will always be located anteriorly, and from anterior to posterior, you will have the renal vein, the renal artery, and the ureter will always point inferiorly. Using those structures, we are able to determine that the image on the right here would be a left kidney, and the image on the left would be a right kidney. The outer structures enable the kidneys, the internal renal structures consist of the cortex, which is the outer layer here. And the cortex contains the glomeruli, the proximal convoluted tubule, and the distal convoluted tubules. The medulla consists of the renal pyramid, the renal columns, and the renal papilla. The renal papilla drains urine into the minor and then major calyces. The renal sinus fat is not present in this picture. However, if it were, it would be in between the major calyces here. And it is responsible for supporting the lymphatic channels and the renal vasculature. Now we will discuss the microanatomy of the kidney. The functional and structural unit of the kidney is the nephron. The nephron consists of the renal corpuscles and the renal tubules. The renal corpuscle is responsible for the filtration of plasma and is a combination of the Bowman's capsule and the glomerulus. Water and low-weight molecules, such as glucose and urea, are filtered from the capillaries through the glomerular filtration barrier into Bowman's space. This filtrate then passes to the renal tubule, and this image here shows the renal cortex and the renal medulla. Note the renal cortex stains darker than the medulla, and you can make out some of the glomeruli present here. And there are also proximal convoluted and distal convoluted tubules located in the cortex. The renal tubule extends from Bowman's capsule to its junction with the collecting duct. Its primary function consists of selective reabsorption of water and other molecules from the glomerular filtrate. There are 3 distinct zones, each with their own corresponding histologic appearance. And the 3 zones include the proximal convoluted tubule, which I will refer to as the PCT, the loop of Henle, and the distal convoluted tubule, which I will refer to as the DCT. And the majority of the renal tubule is present within the medulla. We will only review the histology on the PCT and the DCT. The image on the left here are cross-sections of the PCT, which is the most tortuous segment of the renal tubule. They are lined by a simple cuboidal to simple columnar epithelium, and the lumens are irregularly or stellate shaped. The cytoplasm is also very eosinophilic. The DCT is controlled by aldosterone, and its primary function consists of sodium ion absorption. They are lined by a simple cuboidal epithelium and have a much more uniform lumen compared to the PCT, and the cytoplasm is also much more lightly stained compared to the PCT. Before we discuss the case in my dictation, I believe it is important to review the AAPA grossing guidelines for renal cell carcinoma, since I did follow these guidelines to guide my gross. The AAPA grossing protocols are a set of guidelines that provide a systematic outline for the macroscopic evaluation of cancer resection specimens. They provide all of the information required by the CAP protocols. First, the type of specimen must be indicated, and you may receive a partial or radical nephrectomy specimen. As I mentioned earlier, the orientation of the specimen must be identified to confirm the laterality stated by the surgeon. It is also important to state whether the specimen was received fragmented, intact, or disrupted. And the weight and an oriented 3D measurement should be included, as well as the components received with the specimen, including the perinephric adipose or the adrenal gland. And a description of the tumor should also be noted, describing its focality, site, extent, and appearance. The margins are also very important to include and are usually shaved sections of the ureter, renal vein, and renal artery. It is important to determine if the renal vein is involved by a thrombus and to include a section, because this could indicate that the cancer has metastasized to other parts of the body. This is an image from the AAPA guidelines, which shows sections that are beneficial for the pathologist. Sections that should be included include a section of tumor to the renal capsule and the perinephric adipose, sections of tumor to uninvolved renal parenchyma, especially including the corticomedullary junctions, and sections of tumor to the pelvic calyceal system. These sections provided, along with the gross description, allow the cancer to be staged appropriately. With the PT1 category, the tumor is less than or equal to 1 cm in greatest dimension, and the tumor is confined to the kidney. With PT2, the tumor is greater than 7 cm in its greatest dimension. However, it is still confined to the kidney. With PT3, the tumor extends to the major veins, the perinephric tissues, and the adrenal gland located on the same side. However, it does not extend beyond Gerota's fascia. PT4, the tumor extends beyond Gerota's fascia. The PN category is for lymph nodes. PNO, there's no regional lymph node metastasis. PN1, there's metastasis to the regional lymph nodes. PMO, or the PM category, is just for distance metastasis. PMO, no distance metastasis. PM1, there is a distance metastasis. Now we will get into the case study. The patient is a 74-year-old white male with a clinical history of atrial fibrillation and benign prostatic hyperplasia. He had a CT performed by his primary care physician, revealing a lung nodule and also a renal mass, and the renal mass was an incidental finding. The patient denied hematuria and flank pain, which are common symptoms that correlate to the size of the mass found within the kidney. This is my dictation. We will not read through it. However, we will cover all of the components that make up my gross. The specimen was a left radical nephrectomy weighing 749 grams, measuring 15.5 cm from superior to inferior, 9.0 cm from medial to lateral, and 9.0 cm from anterior to posterior. The specimen included Gerota's fascia, the perinephric adipose, renal vein and renal artery, and the ureter, which measured 7.5 by 0.5 cm. These are two images of the specimen. The image on the left shows the anterior aspect of the kidney, and I know this because I can see Gerota's fascia here. There is also a defect present, and part of the perinephric adipose is missing, and you can see straight into the renal capsule. And if you look closely, you can see this bulging area here, which is abnormal. And this is the posterior aspect of the kidney, and it's glistening, and there is no fascia present. The perinephric adipose was inked black, and the specimen was bivalved, revealing a 9.3 by 9.0 by 7.2 cm renal mass that was localized to the inferior pole. The mass was encapsulated and hemorrhagic with a central firm yellow focus. The mass did not appear necrotic grossly. However, if it did, I would have given a percentage of the necrosis present. Grossly, the mass appeared to abut the renal sinus fat, major and minor calyces, and the anterior and posterior surfaces. The remaining parenchyma was grossly unremarkable with well-defined corticomedullary junctions, and the adrenal gland was absent, and this is important to state the negative. Now we will review the histology from the case. The image on the right is a cross-section of the ureter from my case. The lumen of the ureter is lined by transitional epithelium, and the image on the left is a higher power online image showing umbrella cells which line the transitional epithelium. They are able to change shape depending on if the ureter is distended or relaxed. And the remaining layers of the ureter include the lamina propria, the muscularis externa, and the adventitia. The image on the left shows tumor cells abutting the connective tissue and the major and minor calyces, compared to the normal histology images I showed earlier in the presentation. The renal corpuscles and the renal tubules are not present. The image on the right shows tumor cells abutting the tumor capsule and renal capsule and the perinephric adipose. The cells do not invade through the capsule into the adipose, and if this did happen, the cancer could potentially become metastatic and invade adjacent structures. Before showing the higher power images of the cancer cells, I would like to take a moment to discuss the histologic grading of renal cancer cells. The International Society of Urologic Pathology, combined with the World Health Organization, developed a grading system for renal cell carcinomas based on the appearance of the nucleoli. There are three main types of renal cell carcinomas, including clear cell, papillary, and chromophobe. Currently, only clear cell and papillary carcinomas are graded using this grading system. There are 4 tiers. With G1, the nuclei are absent or inconspicuous, meaning they are not easily seen, and basophilic at 400 times magnification. With G2, the nucleoli are conspicuous, easily seen, and eosinophilic at 400 times, visible but not prominent at 100 times magnification. G3, the nucleoli are conspicuous and eosinophilic at 100 times magnification. And G4, there is extreme pleomorphism and or multinuclear giant cells and or rhabdoid or sarcomatoid differentiation. Grading should be assigned based on the single highest power view showing the greatest degree of pleomorphism. This is why it is important to sample various areas of the tumor that appear different grossly, because the nucleoli will vary depending on where they are located. This is a higher power view of the tumor cells. A majority of the cells have a clear to granular cytoplasm, and they are described as bubble-like. This is a key characteristic feature of clear cell carcinomas. If you look closely, you can see that these cells here appear more eosinophilic and granular than others. Chromophobe renal cell carcinomas characteristically also have a granular eosinophilic cytoplasm, so please do not let these cells confuse you. Compared to the lightly stained eosinophilic cells, there are more cells with a clear cytoplasm. There are also vessels that are small and thin and arborizing, meaning they are tree-like, which you can notice here and here and here. And this is an important diagnostic feature for cases with granular eosinophilic cytoplasm. At an even higher magnification, you can appreciate the granular eosinophilic cytoplasm and the degree of nuclear pleomorphism. For example, this particular nucleus here is smaller and the nucleoli is harder to see. But this particular nucleus here is larger and the nucleoli are much more easier to see, and they're the darker components within the nucleus. And a majority of the nuclei at this power have a prominent nucleoli. As you may have noticed, the morphologic features of renal cell carcinoma overlap, which can make it difficult to diagnose. Immunohistochemical markers are valuable when the morphological features are unable to provide an exact diagnosis alone. IHC is a lab technique used to look for signs of disease within the tissues. Immunostaining is a type of IHC that utilizes antibodies to bind specific antigens. These antibodies are attached to a fluorescent dye or enzyme that becomes activated after binding to an antigen, which allows them to be visualized under a microscope. PAX8, CD10, and CK7 are IHC markers that can be used to identify clear cell carcinomas. Clear cell carcinomas are PAX8 and CD10 positive, but CK7 negative. PAX8 is a transcription factor that is found in the nuclei of neoplastic cells, and when the cells are positive, the nuclei stains black to brown, which you can appreciate here. And CD10 is a membrane marker that stains membranes of cells when positive, and the lighter brown areas are the cytoplasm and the darker brown areas are the actual membranes. CK7 is also a membrane stain that is negative for clear cell carcinomas. It stains positive in papillary and chromophobe types. The brown pigmentation here is a false positive, and the blue pale dots are just the counter stain that the nuclei are picking up. With the aid of the IHC stains combined with the histologic characteristics of the tumor and gross features, the patient was diagnosed with clear cell renal cell carcinoma with a histologic grade of 3 and a stage of PT2A. There were no sarcomatoid or rhabdoid features present, no necrosis identified, and no invasion of the lymphatics or vasculature. All the margins were negative for invasive carcinoma. There were no lymph nodes, therefore the PN category was not assigned, and there was no distance metastasis, so the PM category was not assigned. There are a few treatment options for renal cell carcinoma. If the cancer has spread outside the kidney, if the cancer hasn't spread outside the kidney, the preferred treatment option includes surgery or ablation. If the tumor is less than 4 cm, they are ablated with a cold gas known as cryoablation or a radiofrequency electric current known as radiofrequency ablation. If the cancer has spread or is at a high risk of spreading, immunotherapy or targeted therapy are better options. With immunotherapy, the patient is given drugs such as Keytruda or nivolumab, which enhances the immune system to be better able to identify and destroy the cancer cells. Targeted therapy is exactly how it sounds. Specific parts of the cancer cells are targeted with the aid of medications like Inlyta and Cabometyx. Now we will discuss the etiology, pathophysiology, morphology, and clinical course of clear cell carcinomas. 70 to 80% of renal cell carcinomas are clear cell, making it the most common type. These tumors can be either familial or sporadic. 98% of clear cell carcinomas are associated with the von Hippel-Lindau syndrome due to mutations in the von Hippel-Lindau gene. Environmental factors can also increase the incidence of clear cell carcinomas. This is not an all-inclusive list, and some of those factors include cigarette smoking, hypertension, heavy metals, asbestos, and obesity. It is suspected that clear cell carcinoma arises from the proximal tubules. It usually occurs as a unilateral solitary mass with a yellow to gray to white coloration. The yellow coloration is due to lipid accumulation within the tumor cells. Hemorrhage and necrosis are also common. The mass is usually encapsulated and contained within the renal capsule, and the cellular pattern can be cord-like or tubular, with a large majority of tumors being well differentiated, with some showing nuclear atypia with giant cells present. Clinical features include costovertebral pain, a palpable mass, and hematuria, with hematuria being the most reliable clue. In 10% of cases, all three features can be seen. Other general symptoms include fever, malaise, weakness, and weight loss. Asymptomatic tumors can be slow growing and reach a diameter of greater than 10 centimeters when they are discovered, which was almost the case for the patient. The 5-year survival rate of clear cell carcinoma is 50 to 69%, and this percentage will vary depending on the size of the tumor. Metastatic cases and larger tumors decrease the survival rate to 10%. Xanthogranulomatous pyelonephritis, which I will refer to as XPG, is important to consider because it's a chronic inflammatory condition that can mimic clear cell carcinoma both grossly and microscopically. XPG is a rare chronic inflammatory disorder that invades and destroys the renal parenchyma. The renal and perirenal tissues are destroyed and replaced with granulomatous tissue with lipid-laden macrophages. XPG arises in the renal pelvis and calyces, and then it spreads to the renal parenchyma. The exact etiology is unknown. However, most cases arise from chronic urinary obstruction and infection, and a majority of patients present with a staghorn calculus, which can be seen here in the image on the left. Impaired degradation of bacteria or inadequate host response to chronic infection is suspected to lead to the development of the disorder. This is an image of an XPG case grossed by a pathologist assistant at the clinical rotation that I was previously at. There is chronic lymphocytic infiltration present here and sclerotic fibrous tissue located between the cells. Similar to clear cell carcinoma, there are cells that appear clear here and some that appear eosinophilic with a granular cytoplasm. At first glance, a pathologist could think that this case is possibly clear cell carcinoma. However, the presence of the lymphocytes and fibrous tissue would suggest otherwise. As I mentioned earlier, IHC stains are beneficial in differentiating disease processes when H&E slides alone don't provide a definitive answer. CK818 is a general membrane stain typically used on XPG cases to determine if it is truly XPG. This image is a CK18 stain of the same case. It is negative, however, if clear cell carcinoma were present, this stain would be positive and identical to the CD10 positive stain I showed earlier. There is no brown pigmentation present within the membranes, and again, the blue dots are just the nuclei which absorb the counter stain. I would like to say thank you to Dr. Christian Papa and Dr. Ashley Porter and the entire staff at the Jackson-Madison County General Hospital for ensuring that I had a great clinical rotation. Any questions? Yes.
You said he didn't have the symptomatic, so what, did the clinical history say what got him to the hospital? Like, how did it get diagnosed?
Yes, so he was initially having issues with his lungs, and they decided to do that scan and they found the lung mass. And also within that same image, they saw the renal mass as well. And I asked the pathologist, was there any possibility that these masses could possibly be related? But however, the lung mass was a carcinoid, so it wasn't metastatic from the kidneys to the cancer to the lungs. It was a primary nodule within the lungs.
So just like two separate.
Two completely separate things.
Cool.
Thank you, Kezira. Good work. Do we want to take a quick 2-minute breather? Is everyone okay if we continue on? All right, we're going to continue on. We'll move on to our second-year student, Zoie Ziesmer, with her presentation of atrophic endometrium to serous endometrial carcinoma, a rare but aggressive transformation. Zoie.
Good afternoon. My name is Zoie Ziesmer, and I will be presenting a case of endometrial serous carcinoma. So by the end of this presentation, I hope that you would be able to understand the normal menstrual cycle and how menopause plays a role in the etiology of endometrial carcinoma, compare and contrast type 1 and type 2 endometrial carcinoma, and be able to use the AJCC, explain which anatomical landmarks upstage the specimen, describe the sections needed and pertinent information from the gross to allow the pathologist to sign out the case, and interpret IHC and molecular testing to predict a diagnosis of serous endometrial carcinoma. This is my overview. We're going to begin with a micro and gross anatomy review, go into the demographics, etiology, and morphology of serous endometrial carcinoma, and then go into our specific case, the clinical findings, gross findings, and final diagnosis, as well as discuss the molecular testing and staging. So a brief overview here. We won't be going over everything, but the anatomy of the uterus, we're going to touch on the important features. So we have the corpus uteri, which is the body of the uterus, which has the endometrial cavity and the myometrium. These are the cornu here that lead into the fallopian tube, the fimbriae, and the ovary. I think it's important too to note that the ovary attaches posterior to the fallopian tube, and that will help us orient a hysterectomy specimen. We also have the endocervical canal with the ectocervical mucosa, and then that leads us into the vagina. This can also be a margin here as the vaginal cuff, and we will have our paracervical margin here as well. So regarding the AJCC, a T1 is confined to the corpus uteri that includes the endocervical glandular involvement. And the difference between a T1A and a T1B is the depth into the myometrium. So if a tumor invades less than 50% into the myometrium, it'll be a T1A. And if it extends further than 50% of the thickness of the myometrium, it will be a T1B. So when we're taking those sections in a hysterectomy specimen, it's important to see how far that tumor goes into the normal myometrium. In a T2, the tumor invades the stromal connective tissue of the cervix, but does not extend beyond the uterus. A T3 involves the serosa, annexa, vagina, or perimetrium. And then furthermore, a T3A involves serosa and annexa. T3B has vaginal involvement or perimetrial involvement. Our T4 is when the tumor then invades the bladder mucosa or bowel mucosa. So that anterior or posterior adjacent structures. Next, we'll move into some normal endometrial microanatomy. So here with the C, we can see the stratum compactum, which is the most superficial layer of the endometrium. Then we have with the S, the stratum spongiosum. And with the B, the most deep layer, the stratum basalis. So the stratum spongiosum and the stratum compactum are the two layers impacted by the ovarian cycle, and they are termed the stratum functionalis. And underneath the basalis, we can see the myometrium beginning. So the stratum functionalis undergoes four different stages through the cycle. It is mainly comprised of pseudostratified columnar ciliated epithelium. So here on the top left, we have the proliferative stage, which has a gland and a lot of mitotic cells. And then we have the early secretory stage, which we can see these basal vacuoles and apical nuclei, which is characteristic of this early secretory stage. And then we have the late secretory stage where we begin to see the nuclei move down, and the vacuoles are more apical with these secretions in the inside of the gland. And finally, the fourth stage is menstruation, which it's the breakdown of the stratum functionalis, and we have menstruation. So next, we're going to move into differentiating between type 1 and type 2 endometrial carcinoma. So type 1 is most common. It comprises of 85% of endometrial carcinomas. It impacts women that are typically 55 to 65 years in age, and its tumor morphology is endometrioid. It's usually brought on by unopposed estrogen or obesity, and its precursor is endometrial hyperplasia. The genes infected are the P10 and the KRAS genes, and it's typically indolent, and it will spread lymphatically if it's given the opportunity. Type 2 only comprises of 15% of endometrial carcinomas, and it happens about 10 years later than type 1. So we're looking at 65 to 75 years, and it arises in those with endometrial atrophy and a thin physique. The tumor morphology is serous, clear cell, and mixed Müllerian. Its precursor is the serous endometrial intraepithelial carcinoma, and it is affected by the TP53 gene. Its behavior is really aggressive with intraperitoneal and lymphatic spread. So I have it boxed in red here because that is the type that we will be addressing today. So the demographics and risk factors for endometrial carcinoma are obesity, type 2 diabetes, hypertension, infertility, and PCOS, unopposed estrogen, which kind of go hand in hand because when the endometrium isn't going through its normal cycles, you have a higher risk of developing a neoplasm. Family history, which can be Leaf-Rod syndrome and Lynch syndrome, which are mutations in TP53. Early menarche, which is defined as starting the menstrual cycle before age 11, and late menopause, which is reaching menopause after age 55. It's also associated with IUD use, radiation, and tamoxifen, which is a common breast cancer medication. So briefly, we're going to touch on menopause because it kind of sets the ground for our atrophic endometrium. So menopause is defined as the permanent stop of menstrual periods after 12 months. And in the US, it's typically age 51, and it occurs between 45 and 65 years old. During this time, the ovaries cease their releasing of hormones, and the endometrium becomes thin, inactive, and atrophied. So here we have a photograph of a endometrium that is menopausal, and we can see that we're reduced to the stratum basalis. And so those two functional layers are now gone, and we don't really have many glands left. And here, for reference, we have a premenopausal endometrium. So this kind of lets you know the ground that these neoplasms are arising in. And this is due to progesterone and estrogen stopping from the ovaries. So serous endometrial carcinoma, although it only accounts for 10% of endometrial carcinomas, it accounts for 80% of deaths. It is a bulky, deeply invasive neoplasm that has a papillary and glandular pattern. Again, ages 65 to 75, and all of them are moderate to poor grade. So as we saw earlier, the grading systems, a lot of tissues will resemble their native counterparts, but these only present moderate and poorly graded. The overall 5-year survival rate is 18 to 27%, 90% with postmenopausal bleeding. And the blood tests will be CA-125 antigen positive, which is also an ovarian cancer marker. And these CA-125 levels can also present in low levels in benign conditions such as endometriosis, menstruation, and leiomyoma development. And finally, endometrial carcinoma is the most invasive cancer of the female genital tract. So the etiology of serous endometrial carcinoma, it arises in women with atrophy in the endometrium. It's almost always preceded by serous endometrial intraepithelial carcinoma, and it's uniformly associated with TP53 aneuploidy, which just means this TP53 gene is mutated. And TP53 is a tumor suppressor gene. It's also known as the guardian of the genome. And then when this is mutated, we can have some really bad malignancies occur, and the cell cycle becomes pretty unregulated. So this top row is the progression of a typical type 1 endometrial carcinoma. We begin with a proliferative endometrium. We have a P10 mutation. We end up with hyperplasia here. And then we end up, after a KRAS microinstability, which is associated with MLH1, we can have atypical hyperplasia, and then further into that grade 1 uterine endometrial carcinoma. So this one, type 1, has a more classic progression into a carcinoma, whereas type 2, we go from atrophy. We have a TP53 mutation, and then we're instantly in carcinoma. Although this is a intraepithelial carcinoma, so we do not have stromal involvement. And then we go directly into a high-grade serous carcinoma. So macroscopically, these are large, friable, and bulky tumors that quickly invade into the myometrium and like to exfoliate into the fallopian tubes and invade the ovaries and other peritoneal structures. So here we have a grossly unremarkable cut section of a hysterectomy specimen. You can appreciate the endometrial cavity in the myometrium, and we can also see here, this is a cross-section of the specimen we'll be talking about, and it's very large, friable, bulky, and involves the myometrium and cervix. So our microscopic morphology, endometrial intraepithelial carcinoma is the precursor to serous carcinoma, although EIC lacks stromal invasion. So this is an IHC for P53, and it demonstrates how it accumulates in the nucleus, and we can do a IHC to be indicative of serous carcinoma versus maybe an endometrioid kind. So EIC and serous carcinoma will be positive for this P53 stain. And so we can appreciate in this bottom left photo that there is a papillary growth pattern. And as we'll continue to see through this presentation, these cells will be high grade with mitotic figures, prominent nuclei, cytologic atypia, a high nuclear to cytoplasmic ratio, and they will be hyperchromatic. Now we're going to move into our clinical and pathologic findings. The patient was a female in her late 60s, so she was right in that range that we previously discussed. She was G3P3, so she was fertile. She struggled with obesity, hypertension, and type 2 diabetes. She experienced menopause at age 62 and had no significant history with HPV. She presented in late 2024 for pelvic pain and a bulging sensation from the vagina for 3 weeks. She did not report any change in bladder or bowel habits. They did a pelvic ultrasound, and it revealed an enlarged uterus with a thickened endometrium. They went ahead and biopsied the endometrium, and it revealed endometrial adenocarcinoma. They also performed a pap smear, and it was positive for adenocarcinoma and HPV negative. She presented months later in early 2025 and had a CT done, and it showed pulmonary nodules, mild retroperitoneal lymphadenopathy, which just means her lymph nodes were swollen, and abnormal endometrium along with multiple uterine fibroids. At this point, she was reporting persistent yellow discharge and postmenopausal bleeding. On physical exam, the mucosa of the vagina was inflamed with moderate amounts of purulent discharge, and the tumor was grossly appearing to extend beyond the cervix. And they went ahead and biopsied the cervix at this visit. So that will lead us into our gross findings. The first specimen I received on this patient was a cervical biopsy 2 days prior to the hysterectomy. It was a small aggregate of friable red-pink tissue. I completely submitted it, and the diagnosis was high-grade adenocarcinoma, most consistent with a high-grade serous carcinoma. So here's the H&E of the biopsy. we can see that pretty much the entire piece of tissue is taken over by this papillary glandular structure. We have a lot of nuclei, it's very purple. If we zoom in here, we can appreciate the papillary nature of this tumor even more so. And we also have lymphocytic infiltrate, very prominent nuclei in our cells, which we can kind of just see throughout this whole tumor. And overall, it's very high grade. So this is a P53 stain that was done during the workup on this cervical biopsy, and it was uniformly very positive. So that led this pathologist to the diagnosis of serous endometrial carcinoma or serous carcinoma. We'll see endometrial later. So the second specimen that I received on this patient was a uterus with cervix, bilateral fallopian tubes, and bilateral ovaries, as well as bilateral pelvic lymph nodes and a omentum biopsy. They also performed a pelvic washing, which was inconclusive, but the reason they tend to do pelvic washings with these is they love to spread intraperitoneally, so if they have any malignant cells in the peritoneum, we could potentially see that here. So anatomy and orientation of our specimen. We have the anterior and the posterior. On the anterior, you can appreciate that the serosa does not quite go as far down as it does on the posterior side. It's hard to see with all the nodules, but we have our ovaries and fallopian tubes, which insert posterior to the fallopian tube. And we also can appreciate all the subserosal nodules. Here we also have dye present at the anterior paracervical margin, which was part of the sentinel lymph node biopsy that they performed. I think this is a good time to go over the margins in a hysterectomy specimen. So according to the AAPA, the only true margin here is the paracervical tissue. So we have mucosa at the ectocervix, as well as serosa outlining the hysterectomy, the uterus, the fallopian tubes, and we have a germinal epithelium, which is an extension of the peritoneum on the ovaries. So this is really the only margin here. So we will not read my entire gross description, but this is the outside of the specimen. It was noted to weigh 493.9 grams. The average hysterectomy specimen that is benign, according to the AAPA, weighs between 40 and 80 grams. It's very enlarged. Our os had tumor protruding through, and the serosa was congested with multiple subserosal nodules. And like we said, we can see the sentinel dye. So here's a photo demonstrating the os with tumor protruding through. You can see it right here. There was also tumor in the bucket, so it could have been worse before I received the specimen. Here's my specimen bivalved. I wasn't able to find any unremarkable endometrium in this specimen. It was entirely consumed by a tumor. It was very friable, very necrotic. So its greatest dimension was 14 centimeters, and it extended into the lower uterine segment into the endocervix and ectocervix. So I went ahead and I inked my anterior paracervical margin blue and my posterior paracervical margin orange. And then I measured when I went to do my sections how far it went down to the ink. So they're right here. We don't really need to read them. So these were the cut sections. On the left, we have anterior and posterior. So we can see that this tumor has this white scalloped border, and it's going pretty much down to the ink on both anterior and posterior. Here's my greatest depth of invasion. We can see that this mass is not quite invading the serosa, but it's coming pretty close. It's definitely over that 50% threshold that we have for the AJCC. Here's my cassette summary. I went ahead and submitted my anterior cervix with that paracervical margin interface. the posterior cervix, the lower uterine segment with the paracervical margin interface, and my deepest invasion with serosal interface. And then we also submitted the fallopian tubes and ovaries with some of the subserosal nodules. So here's a micrograph of my posterior paracervical margin. It's approximately right in here that we'll be seeing. So I think it's closest right over here. And this is why it's really important that we ink our margins, is because at the microscope, the pathologist can see that ink and see if those tumor cells are going up to the ink. So in this case, this posterior paracervical margin was positive, and the tumor is invading up until that posterior orange ink. The final diagnosis was serous carcinoma, 14 centimeters in greatest dimension. The carcinoma invaded the myometrium to a maximum depth of 1.1, which the total thickness was 1.3, so we're way over that 50%. The carcinoma closely approaches but does not appear to involve the uterine serosa. Carcinoma deeply invades the myometrium to the level of the lower uterine segment. The carcinoma extensively invades into the cervical stroma to a maximum depth of 1.3 cm. The carcinoma did not involve the bilateral tubes or ovaries. The posterior paracervical resection margin is positive, and our pathologic stage was PT2, PN0. And for gynecological specimens, they also follow a FIGO staging system. And so the only difference really between FIGO and AJCC is FIGO accounts for the type of malignancy. So we are at a 2C, which if it was a less invasive, maybe an endometrial carcinoma, it might be a 2A or a 2B. And then her HER2 was positive and MMR was negative. So our specimens that came with the hysterectomy, we had the left pelvic lymph node and the right pelvic lymph nodes, which were negative for carcinoma, as well as an omentum biopsy, which luckily was just benign fibroadipose tissue with focal mesothelial lining, which was compatible with a hernia sac. For molecular, HER2 IHC was done, and HER2 cancers arise from gene amplifications on certain chromosomes. They are oncodriver mutations. TP53 mutations are heavily associated with HER2. HER2 overexpression can be detected and targeted in chemotherapy. So the patient was overwhelmingly HER2 positive and FDA approved for HER2 chemotherapy. So that's why it's really important that they go ahead and do this IHC, because then they can proceed with treatment. She was also tested for MLH1, and it encodes a component of the MMR, which is mismatch repair complex of proteins, and a loss of function can cause microsatellite instability in about 20% of endometrial carcinomas. A MLH1 promoter methylation analysis was performed and positive. This positive result essentially excludes 95% of Lynch syndrome cases and mismatch repair gene product loss. So it basically just lets us know that she does not have Lynch syndrome. So for the T category, we're sitting at a T2. We invade the stromal connective tissue of the cervix, but we did not invade beyond the uterus. We're sitting at a PN0. There were no regional lymph node metastases, and we can grade this because we did receive lymph nodes. And we're in an M0. She luckily had no distant metastases that we know of, although that CT scan did have some findings that weren't investigated yet for now with the omentum biopsy, and what we know, we're at an M0. I want to give a special thanks to Ashley Henry, Dr. Morberry, and Dr. Body, which were the PAs and doctors that I worked with on this case. And here's my references. Thank you. Any questions? Yeah.
Thinking back, and they already knew she had why didn't, why they just leave it?
Yeah, I kind of wondered the same thing myself, and I even further questioned why they did this cervical biopsy if she had a positive endometrial biopsy. We didn't really have a quite clear answer. A lot of the times they will do a biopsy to make sure that insurance will cover the procedure for a hysterectomy. But yeah, maybe just the patient's life and how often she could come into the doctor or what worked out for her life. So, yeah, no clear answer, but yeah, thanks. Yes.
Did you have any considerations before you opened the uterus?
So I think my biggest cautions were the tumor protruding from the os. So I definitely, of course, inked it before I opened it. But it was difficult to open as well because of the nature of the tumor. It was very friable. So I did let this specimen also fix overnight before I grossed it. But that was pretty much.
How did you open it?
So I like to probe the os, and then I will use scissors when it's convenient, but in this case, with it being so large, I took a large blade and just followed my probe down the os into the endometrial cavity.
It was a good clean cut.
Thank you. All right, thank you.
My apologies for the mispronunciation of your last name, Zoe. We will, this ends our presentations for today. We will convene a month from now, Friday, May 2nd, from 12 to 1 o'clock. Please note the change in location. When we come back next week, we'll be in the General Education Building, room A304. Thank you. Have a great weekend.